Hello, and welcome to Facebook Live. My name is Dr. Mark Keegan. I'm a neurologist and the division chair of multiple sclerosis and autoimmune neurology at Mayo Clinic, Rochester, Minnesota. And I'm very happy to meet with you today and discuss some things regarding multiple sclerosis and the COVID-19 pandemic. I'm going to speak for about 20 minutes or so, and then there shall be a question and answer period following that, where there's any questions at all that you have for me on this topic. I'll be very happy to address those. Just as an outline to initiate our discussion today, first of all, I'm going to talk to you about symptoms of attacks of multiple sclerosis and how they may differ from the symptoms of COVID-19 infection. Following that, I'm going to speak in some detail about the implications of having multiple sclerosis during the COVID-19 pandemic. Then I've gotten a lot of questions from our patients and others about what should I do about starting disease-modifying therapy for multiple sclerosis during this pandemic, or continuing my disease-modifying therapy for multiple sclerosis during the COVID-19 pandemic. And lastly, I'll discuss some of the resources that are available for patients with multiple sclerosis regarding MS in general, as well as those specifically related to the COVID-19 pandemic. So as I mentioned, I'm going to start off with discussing some of the typical symptoms of MS. And the symptoms of attacks of multiple sclerosis are actually very typical, and they're very specific. So they're not usually difficult to understand. One of the things that we talk about to patients here is sort of a 24-hour rule that a new onset attack of multiple sclerosis should last at least 24 hours in duration. It usually lasts many days or weeks, to be honest, but the 24-hour rule is helpful in that it discriminates that from other non-specific symptoms that last 10 minutes, 1 hour, or less in duration that we generally don't have to worry about in terms of attacks of multiple sclerosis. Now, the other things about attacks of multiple sclerosis is they should come independently. They shouldn't only be due to fatigue or ongoing infection with COVID or any other infection. Urinary tract infections are more common, stress, or just exhaustion and fatigue. So they shouldn't come with that. They should come independently. And when you look at attacks of multiple sclerosis, they come depending on what level of the nervous system is affected by the inflammation of MS. And multiple sclerosis, as many know, affects only the central nervous system. And the central nervous system includes the brain, the back of the brain called the cerebellum that controls balance, the brain stem where many of our cranial nerves live, the optic nerves, and the spinal cord. That's the central nervous system: the brain, optic nerves, cerebellum, brainstem, and spinal cord. And when there's inflammation of those areas, they give very characteristic symptoms. For instance, if there's inflammation of the optic nerve, people get what's called optic neuritis, and they develop usually painful loss of vision, usually in one eye only, that again worsens over a number of hours to days, stays impaired for a number of weeks, and then improves over time. That's a very characteristic symptom of optic neuritis: painful, unilateral, meaning one eye only, loss of vision. Another typical symptom of multiple sclerosis attacks is that of double vision, or what we call diplopia. And what that is where you see two images, and that is usually without any pain at all. It should be painless, and again, usually lasts many days in a row, but it should last at least 24 hours in duration, and it should be constant, double vision. And the thing about the double vision is it should go away if you close one eye or the other eye, and that's what we call binocular diplopia, meaning it is only present double vision with both eyes open, and it's without pain. Other symptoms of multiple sclerosis attacks include loss of sensation or weakness all on one side of the body, face, arm, and leg on one side or the other side. 24-hour rule is maintained. You should have it for at least 24 hours in duration and usually many more days than that. Another symptom that's very typical of MS attacks is that of a sensory myelopathy. What we mean by that is some inflammation within the spinal cord, which means a myelopathy, where people lose sensation, often in the feet, slowly going up their knees, belly, chest, all the way up to their side or neck even. Again, usually worsening over hours to days, lasting at least 24 hours, but usually many days in duration, sometimes accompanied by weakness. But even loss of sensation in that pattern could suggest an inflammation in the spinal cord, or what we call an inflammatory myelopathy. Now, those symptoms are actually very different from that we've been hearing about are the typical symptoms of COVID-19 infection. The symptoms of COVID-19 infection are usually heralded by a fever, at least 100 Fahrenheit or more. Sometimes people do get muscle aches and diffuse pain. It has been recognized that people may lose their sense of smell or of taste during an acute COVID-19 infection. Fatigue is a component of that and is also a component of multiple sclerosis, but it's really those other significant symptoms: severe fever, sometimes chills, muscle aches, and sometimes loss of sense of smell or of taste. Now, there are other symptoms as well: severe shortness of breath, deoxygenation of the blood when the lungs are affected by severe COVID-19 infection, and even shortness of breath due to heart failure. Some of those more significant symptoms, will require hospitalization, of course, and are found to occur more in older patients or those with pre-existing comorbid diseases like high blood pressure, overweight or obesity, and diabetes mellitus. As you may have heard, sometimes infections with COVID-19 are asymptomatic or minimally symptomatic, and so that's why precautions are required for people when they go out, accompanied by other people, or in situations like a medical examination at Mayo Clinic. All of our physicians and our patients are masked, and they're only allowed one visitor to their appointments to keep a very safe environment, because many people may not be symptomatic even though they have an acute infection with COVID-19. So those symptoms of COVID-19 infection and of attacks of multiple sclerosis are very different, but they need to be recognized as different. Now, secondly, I wanted to talk about what are the implications of having multiple sclerosis during the COVID-19 pandemic. A couple of those things that are important is just simply having multiple sclerosis likely does not put you at greater risk to develop symptoms or severe impairment due to COVID-19 pandemic. That's particularly in those that have multiple sclerosis but are doing well with it. These are not people that are with severe long-term MS that are in nursing facilities, which are at greater risk. As we have heard about, those in nursing facilities are at high risk to develop complications of COVID-19 infection and dissemination in their areas where they live. The real thing in terms of multiple sclerosis and COVID-19 infection comes with the use of disease-modifying therapy for multiple sclerosis. And some people have not yet been on disease-modifying for MS. Many others are already on a disease-modifying medication for multiple sclerosis. And there are about 15 or so approved medications for multiple sclerosis. And one way to divide those up is really injectable medications. The oldest medications we have for MS, which are called interferons and glatiramer acetate, they're by injection. the oral medications for multiple sclerosis. There are 3 approved oral medications, or 4 approved medications with some with similar class of action. Teriflunomide, dimethylfumarate, and then fingolimod and siponimod, which have a very similar mechanism of action. And then there are infusion-based medications for MS, some which particularly affect the CD20 cells, called the B cells of our body and immune system, and others called natalizumab, which block the immune system from, or the immune cells from gaining entrance to the brain and spinal cord. And lastly, more immunosuppressive medications, almost like chemo medications, like alemtuzumab, which suppress both the T cells and the B cells of our immune system. And it's not really clear, because of the new evidence of this virus, how people will respond to everything. But given the mechanisms of action of these medications, we do suspect that we can make some conclusions about initiation of them and maintenance of medications for MS. I'll start off with the earliest medications, meaning injectable medications, the interferons and glutaramyl acetate. Those are thought to be quite safe for the pandemic of COVID-19. Glutaramyl acetate has a mild effect on the immune modulatory system, but it doesn't seem likely that that would be affected at all by COVID-19 infection or exposure to COVID-19. That medication is also better known as Copaxone, glutaramyl acetate. Interferon medications, which are different classes from Rebif, Betaseron, Avonex, Plegridy, Betaseron, they are beta interferon medications, and they are suspected to be very safe in terms of the COVID-19 pandemic. In fact, there has been recent study of beta interferons as part of a cocktail of medications for treatment of COVID-19 infection. But that's not standard of care by any means, but it does hint at that the use of beta interferons, as I mentioned, are likely safe for continuation of treatment or initiation of treatment for the COVID-19 pandemic. As I mentioned, there's 3 different oral medications for multiple sclerosis, and teriflunomide and dimethylfumarate both act on the immune system. Both are suspected to likely be safe in terms of the COVID-19. Again, none of this is proven by any means because of the novel nature of this COVID-19 virus. Fingolimod and siponimod have a similar mechanism of action. They sound the same, and they have a similar mechanism of action, which is entrapping the immune cells within the lymph nodes itself. And because of that entrapment, some immune cells are available to fight off infections, but some are not. And one concern about fingolimod and possibly siponimod is infections such as herpes-like viruses. Now, that has uncertain effect with that of COVID-19, but there is some suspicion that it could expose someone to complications related to COVID-19. I don't think that's been proven by any means yet, but there is at least a hint of that being a possible concern. Here at Mayo Clinic, we haven't recommended people come off fingolimod or siponimod at this time, even given this effect. We do recommend, of course, for everyone, no matter what medication they are on, or if they're on no medications for multiple sclerosis, that they continue to stay safe with social distancing recommendations, masking where it's appropriate and needed, and other ways keeping away from people that are actively ill, and maintaining quarantine if they have symptoms of viral infections. Lastly, I discussed that there are infusion-based medications for MS which have different mechanisms of action. I'm going to consider natalizumab, or what's called Tysabri, first, and that is a medication that prohibits the immune cells from entering the central nervous system, which is affected by MS, the brain and the spinal cord. It blocks that transfer of those immune cells into the central nervous system, so they're maintained throughout. And it seems, from what we know about MS, that that would be a safe medication to maintain during the pandemic. And that's generally given every 4 weeks. Some people give it every 6 weeks. And initially during the pandemic, we suggested some patients delay that for about up to 6 weeks after their last infusion, which seems to be a safe procedure. But that was also because we didn't recognize exactly what would be going on and whether people would be more at risk if they presented to infusion centers on a more regular basis every 4 weeks. Right now, we think that most people can return to every 4 weeks therapy, given what I know, or maintain on every 6 weeks therapy from that. It's also important to recognize that people should not come off their disease-modifying therapy without consultation with their MS providers. For instance, for natalizumab, that's the Tysabri that I just discussed, if it is stopped, there does appear to be rebound of inflammatory disease after discontinuation of Tysabri or natalizumab. And that's important because we don't want to have people having acute attacks of multiple sclerosis that need evaluation. So they need to maintain on that medication in by far the most cases. Now, another medication that acts on the CD20 or the B cells is called ocrelizumab or Rituximab. Rituximab is not FDA approved for MS, but some physicians have been recommending it for those patients. But they have a shared mechanism of action, which is reducing the CD20 or B cell profile for MS. And it has a longer lasting effect. It's infused after the first infusions every 6 months. And the considerations for that is that, well, it's not certain whether that would make you any more likely to develop infection or complications of COVID-19 infection. In fact, some have suggested that reducing the immune system may be beneficial for those so they don't develop a more severe cytokine storm, which happens with some of the severe cases of COVID-19. That the prolonged mechanism of action means that it could be delayed a number of weeks or even a month or longer with us still maintaining the disease-modifying effect on their MS, a good effect on MS. So we have delayed some patients' infusions because of that. There is a way to monitor the CD19 levels to see if the B cell remains reduced in patients with ocrelizumab, and that's a treatment option that some MS providers will check to see if the maintenance of good effect of ocrelizumab or rituximab is maintained and whether you can delay another infusion. One medication, as I mentioned, called alemtuzumab, is a very broad immunosuppressive medication, and it reduces both T cells and B cells. And because of that broad reduction in immune cells and the long-lasting use of Lemtrada, it's given 5 days the first year and then 3 days the next year. Those, I think, patients do need to maintain more restriction and caution with that. In fact, we generally haven't started people on Lemtrada in the midst of the pandemic because of that, or alemtuzumab. And some patients that have been due for their next dose, their 3 doses of the next year, have delayed that therapy while we monitored the situation, and they've either chosen to remain off and see how things go, or initiated alternative disease-modifying therapy for MS, one of the other evaluations that we've been thinking about with alemtuzumab because of its broad reduction in immune response. Lastly, I want to talk about the resources that are available to patients with MS during the COVID-19 pandemic. And first of all, for those patients with multiple sclerosis, there's a very nice evaluation on the National Multiple Sclerosis Society webpage, nationalnmss.org. We provide patients information about that, as in addition to the own information that we get from our physicians at Mayo Clinic and our nursing staff, our comprehensive nursing staff at Mayo Clinic. We direct people to the website of the Centers for Disease Control and Prevention, the cdc.gov. That gives a very updated recommendations on a number of things. in terms of COVID-19. It's rapidly changing, as people know, so keeping an updated review of both the National MS Society webpage and that of the Centers for Disease Control and Prevention, cdc.gov, is very important. In addition to that, we have encouraged people that have maintained their employment and their job to contact their human resources and occupational safety at their own location to examine what type of infection exposure risk they are at and what kind of things are done on their local level. This is important because different jobs and different job sites and employers have different recommendations for their job, and that's important for the physician and their treatment staff, nursing staff, and the patient group that are helping out with somebody to understand that we provide information about their MS, what medications they're on, what to expect from that, and then they decide independently from their employer about what is best for that particular job site. Those are the topics that I wanted to make sure that people hear about: the symptoms of attacks of multiple sclerosis, which are very characteristic, specific for multiple sclerosis, and how they differ from acute infection of COVID-19 pandemic. That the implications of simply having multiple sclerosis during the pandemic are likely small, but the real question is about initiation of new disease-modifying therapy for multiple sclerosis. How do we make that judgment based on the different mechanism of action of all the 15 or so medications that are approved for MS? And in continuation of specific disease-modifying therapy from the injectable medications, which seem so safe, interferons and glatiramer acetate, oral medications generally thought to be safe, but fingolimod and siponimod, some special circumstances with that. Infusion-based medications like Tysabri, that's natalizumab, which seem to be safe given the mechanism of action of stopping the immune cells from entering the central nervous system. From some caution with CD20 medications that have a very long, prolonged mechanism of action, but they only affect the B cell side and may be safer than we anticipate. And then broad spectrum immunosuppressive medications like alemtuzumab, where I think there certainly is caution about probably not starting many patients on that medication and delaying their infusion as scheduled because of the mechanism of action of that. And lastly, I commented on the resources available to people with multiple sclerosis, the National Multiple Sclerosis Society, and the Centers for Disease Control. And after I've discussed all that, I do see that I'm starting to get some questions which I will be very happy to address. The first question, as I can pull it up, I think, do you have thank you for hosting today. It's my honor. Thank you very much. Do you have advice for multiple sclerosis patients transitioning to telemedicine appointments during social distancing? Well, that's a fantastic question, and in fact, we at Mayo Clinic initiated a lot more. We always did telemedicine. We did virtual appointments, but we increased the number of telemedicine and video appointments that we had with our MS as well as our general neurology population as well. I think that for report visits after somebody's had an MRI scan, talking about symptoms, they are absolutely excellent. You can get a lot of information by video appointments to discuss the issues that patients are having, side effects of medications, counseling patients, just like I'm doing today. I think that's very important. Of course, it's entirely safe by video, and most people do have access to that type of care, which is very good. One drawback is it's very difficult to get an idea of what things look like from a neurological examination on a video review. There are a few things that can be done from a neurological examination, but much of that does need face-to-face review or mask-to-mask review as we have at Mayo Clinic for our safety of our staff and patients. And increasingly, over the last couple of weeks, we have been seeing particularly new patients, but even established patients that we've seen before, in that environment so that we can safely examine them, mask patients. We even use safety goggles for our staff here. So that's determined to be very safe evaluation. And so we've continued to reinitiate face-to-face reviews in addition to video reviews. And I think video reviews will continue to be important for our care with our patients, especially return patient care and established patient care. But it is always good to see people initially and be able to examine them neurologically. Thank you very much for joining me today, and it's important information that I think we've discussed today, and I'm hopeful that people will maintain their safety with social distancing, all the recommendations that are being made, and fortunately the things that we're hearing from people even in very affected nations like Italy, Spain, and now increasingly the United States, that patients with multiple sclerosis can be safely treated. They maintain safety. Even those that become infected seem to be doing quite well, and that's a very big relief for physicians, nursing staff, and our MS patients and their families. So that's very encouraging news. And I hope you all maintain safety, and it's been my honor to discuss that with you today. Thank you so much. Goodbye now.